So, so today we will discuss about the blood pressure, right? So blood pressure, there are a lot of guideline on the blood pressure. I'm following the first aid. So first aid says that the systolic blood pressure is more than 130 and diastolic blood pressure more than
80.
80. So there are a lot of guidelines and a lot of variability.
I think 90. No.
No. There is a
Okay.
lot of guideline, but I'm following the first aid. So first aid mentioned 80 diastolic, right? So the blood pressure has a two component, systolic and diastolic. What is the blood pressure is equal to cardiac output and TPR, right? So
Yes.
this TPR determines the diastolic blood pressure mainly, and this cardiac output determines the systolic blood pressure. Generally speaking, right? So if there is increased cardiac output or increased stroke volume, so there is increased systolic blood pressure, right?
Yes.
Okay. So TPR, if the TPR afterload is increased, it will also affect on the systolic blood pressure as well because of the response. Left ventricle generate higher pressure and it will generate increased systolic blood pressure. So what about the blood volume? Does blood volume has any correlation with blood pressure?
Yes.
In which? Diastolic and systolic.
I think I'll be diastolic.
Okay. So blood volume has increased systolic as well as diastolic. So because blood volume increase, preload as well, right?
Yeah. Yes.
In this way, increase preload, increase and diastolic volume and increase
And
stroke
systolic.
volume, increase stroke volume or cardiac output, right?
Yes.
So I hope it makes some sense. Okay. So blood pressure. So this is again a high yield concept. Let's suppose a 40-year man normal and 70-year old normal man. Both are normal. So USMLE love to ask the difference in between. They give you some sort of the studies. They follow that person from 20 to 30 years. And what are the changes take place at 70 years of normal person? What about systolic blood pressure? What about diastolic blood pressure? And what about pulse pressure? So what happened in age related, increased age is associated which kind of the hypertension mainly?
Isolated.
Isolated, isolated
Systolic.
systolic hypertension.
Can you repeat that, please?
I say that increased age is associated with systolic hypertension. Why systolic hypertension? Because of
Aortic stenosis, calcification.
age related stiffening of aorta. It may be calcification, it may be due to the atherosclerosis,
Okay.
right?
Yes.
age-related changes, calcification, atherosclerosis, right? So aortic stenosis lead to a change that left ventricle generate higher pressure. To overcome this, increase afterload, right?
Yes.
What happened to the diastolic blood pressure?
Unchanged.
Maybe unchanged, and maybe decreased. Maybe unchanged, unchanged. What happened to the pulse pressure?
Um,
Unchanged
Okay.
or increased.
What happened to the pulse pressure? What is the formula of the pulse pressure?
Systolic blood pressure minus diastolic.
Systolic blood pressure.
No, I said it's systolic minus minus diastolic. Systo
Okay. Okay.
S SBP minus DBP.
Okay. So pulse pressure is increased, right? So the
Yes.
diastolic blood pressure remain controversial. It may be unchanged, maybe increase or maybe decrease, right? So we focus on systolic, and pulse pressure, right? So if the systolic blood pressure is increased, the pulse pressure is also increased. So pulse pressure is also dependent on the stroke volume. So stroke volume also lead to the increased stroke volume, increased systolic blood pressure, increased systolic blood pressure lead to the increased pulse pressure. So this is a very high yield concept. You found it in a lot of questions. Does it make some sense?
Yes.
Okay. So now on regulation of the blood pressure. So there are a lot of mechanisms, but I am talking about the two mechanisms. Regulation of blood pressure. Regulation of blood pressure. Minute acute. Acute mean minute to minute regulation. Which mechanism? We already discussed about in detail. What about long term? This is acute or more precisely short term regulation. Short term regulation. And this is long term regulation. So long term regulation through which mechanism? Can anybody tell? Long term regulation of the blood pressure through which mechanism?
I'm not sure.
Renin, angiotensin, aldosterone system. And the short term regulation mainly through
Chemo.
baroreceptors, right?
Yes.
Okay. So first we discuss about the baroreceptor reflex, right? So baroreceptor reflex is again a important stuff. Baroreceptor reflex. Okay, this picture shows that some key things in the baroreceptor reflex. So what is the stimulus in this picture? Hello?
Yes. Hello.
So let's suppose I give you the example, decrease blood pressure. So decreased blood pressure is baroreceptor or the pressure receptor that detect the change in pressure. So decrease in blood pressure takes place. So the baroreceptor located in aorta and carotid sinus, right? So from the aorta, the signals goes through to the brainstem through the vagus nerve, which is a cranial nerve 8. And from the carotid sinus, the signal goes to the brainstem through the glossopharyngeal nerve, which is a cranial nerve 9.
9.
Right?
Yes.
Okay. So, if there is a decreased blood pressure detected by the baroreceptor, right?
Say that again. If there's decreased blood pressure, what happens?
Okay. If there is decreased blood pressure, that is detected by baroreceptors.
Yes.
So baroreceptors, what will they do? They send signal to the brainstem
To the brain. Yes.
through two pathways, cranial nerves, right? So
Yes.
in brainstem, particularly the medulla. Can anybody tell me the nucleus that present in the medulla?
Solitary nucleus.
Solitary nucleus. The solitary nucleus. So this medulla signals cause increased sympathetic activity and decrease parasympathetic activity. Right?
Yes.
And it ultimately lead to increased blood pressure and which may lead to normal or blood pressure. So initially there is a decreased blood pressure, right? So this reflex is basically the short-term regulation of the blood pressure, right?
Yes.
So baroreceptor reflex is a short-term regulation of the blood pressure. Okay. Any high yield pathology that impair this reflex?
Beta blocker.
Postural hypotension, right? There are a lot of causes of the postural hypotension. You're right, drugs, beta blockers, autonomic neuropathies, long-standing diabetes, they will lead to the postural hypotension. The postural hypotension disrupt this reflex, right?
Yes.
Okay, so this is baroreceptor reflex. So this is the most high yield stuff. Renin, angiotensin, aldosterone system. So this is for long term blood pressure regulation. Long term blood pressure regulation, right? So if there is a this is macula densa. Macula densa present in the distal convoluted tubule. Macula densa detects sodium chloride, right? And this is juxtaglomerular cells. So juxtaglomerular cells located in efferent arteriole. Certain modification in the smooth muscle of the arteriole. This arteriole. This is JJ cells, right? So whenever there is a decreased blood pressure, it will lead to decrease GFR. Decrease GFR lead to decrease sodium chloride delivery to macula densa, right? This decreased sodium chloride delivery to the macula densa cause a change. Increase renin from which cell? From which cell? JJ cells, right? So renin is
Yes.
enzyme that convert this angiotensinogen that is synthesized by the liver into angiotensin 1. So angiotensin 1 is converted to the angiotensin 2 by an enzyme called
Yes.
angiotensin converting enzyme, right?
Yes.
Mainly in the lungs.
Lungs.
So this enzyme is also important for breakdown of the bradykinin, right?
Yes.
Can anybody tell me the drug that will inhibit this enzyme?
Yeah. ACE inhibitor.
ACE inhibitors. So ACE inhibitors, again, pharmacology, integration with physiology, high yield stuff. So ACE inhibit this process, right? So ACE,
Yes.
if the patient is taking ACE, what will be the level of what will be the level of what will be the level of the bradykinin in this patient? Increase,
It will be.
decrease,
It will be high.
sorry,
It's going
sorry,
to be high. It's
increase
going to be
bradykinin,
high.
increase bradykinin. So increase bradykinin lead to angioedema, right?
Yes.
And dry cough. Okay, can anybody tell me the contraindication of the angiotensin converting enzyme inhibitor?
During the
Yeah.
pregnancy.
A, a person who has C1 esterase deficiency is not supposed to take.
Yes.
Yes, this is
Related to
again high yield
angioedema.
stuff. C1 esterase inhibitor deficiency is a contraindicated for ACE, right? It also contraindicated in pregnancy, right?
Yes.
Okay, I'm again repeating the concept. Someone say that, can you please repeat the bradykinin? So this ACE that convert angiotensin 1 to angiotensin 2 is also involved in the breakdown of the bradykinin, right?
Yes.
So if the patient taking the ACE inhibitor, so the level of the bradykinin will increase in that patient. This is simple. Does it make some sense? Someone asked this question on chat. Sayaka MD. Does it make sense? Bradykinin is increased in the patient who taking ACE inhibitor, right?
Yes.
Okay. So this angiotensin 2 is active. It will has a multiple effect on the body. It will act on hypothalamus, increase ADH release from the posterior pituitary, and it will lead to the increased water reabsorption through aquaporins channel. Okay, so it will act on adrenal cortex. Adrenal cortex, release of aldosterone. So aldosterone, so adrenal gland has two portions: cortex
Medulla.
and medulla. So medulla is derived from which germ layer? Which cell?
Neural
Neural
crest.
crest. Neural crest. Right?
Yes.
And cortex is derived from mesoderm.
Mesoderm.
So cortex is further divided into the three layers: glomerulosa,
Fasciculata
fasciculata,
and
and
reticularis.
reticularis. So aldosterone is released from which layer?
That would be from glomerula.
Glomerulosa, right?
Glomerulosa, yes.
Okay. So it will increase aldosterone, increase aldosterone, increase this aldosterone, increase sodium,
Sodium retention,
decrease potassium,
and also
decrease,
hydronium.
right. So this increase hydrogen, this increase sodium lead to water reabsorption. Okay. It will also directly act on the uh, efferent arteriole. It will constrict the efferent arteriole, increase filtration fraction, and preserve GFR. Right? It also lead to the vasoconstriction directly, so increase blood pressure. Right? So
Right.
JJ cells has which receptor? JJ cells has which receptor?
B1.
B1. So if you are taking beta blockers, so beta blocker inhibit this system, right? Very high yield. So beta blocker decrease blood pressure. Beta blocker decrease blood pressure. So this is a mechanism of with the beta blocker. Decrease blood pressure through inhibition of beta 1 receptor on JJ apparatus cell. And it also decrease the cardiac output through which receptor? Again, beta 1 receptor that present on the heart, right?
Yes.
We will discuss these drugs in detail, but I am correlating the high yield stuff that is important for you, right? So does
Yes.
renin angiotensin aldosterone system make some sense for you?
Yes.
Any question regarding this system? It is mainly for the long-term blood pressure regulation. Okay. I'm changing the slide. Okay. Hypertension classification. Okay, is my screen is visible or not?
Not yet.
Yeah, I will try it again. Okay, what about my screen? Visible or not?
Yes. It's visible now.
Okay, so the hypertension is mainly classified into the two types. Primary hypertension. So primary hypertension is also known as a essential hypertension. So can anybody tell me the cause of the primary hypertension?
I do بس.
Idiopathic, right?
Okay.
So the secondary hypertension, that is a very, very high yield. Secondary hypertension. So the secondary hypertension due to the renal parenchymal disease, right?
Yes.
Can anybody tell me the one disease of the renal parenchymal disease?
Fibromuscular dysplasia.
Nephritic syndrome, right?
Yes.
How nephritic syndrome lead to the hypertension? Can anybody tell me the pathophysiology? So nephritic syndrome damage glomerulus, right? Damage glomerulus.
Basement membrane.
So it will lead to the decreased GFR. So if GFR is decreased, decreased sodium chloride delivery to the macula densa, right? And this lead to increased renin. And increased renin will activate the renin angiotensin aldosterone system, and it will lead to hypertension. Does it make some sense? Does it make some sense?
Can you run over it one more time?
Okay. So the renal parenchymal disease or nephritic syndrome or glomerulonephritis. Nephritic syndrome or glomerulonephritis. It is a name, multiple name of the one thing. Okay. It will lead to damage to glomerulus. Yeah, glomerulus. So damage to glomerulus lead to decreased GFR. Decreased GFR lead to the decreased sodium chloride delivery to macula densa.
Densa. Okay.
So decreased sodium chloride delivery to the macula densa, increased renal release from JJ cells, and this increased renin will activate renin angiotensin aldosterone system, and it will lead to increased blood pressure, and in this way it will lead to the secondary hypertension. Very high yield, very high yield. Okay, the renovascular hypertension. Okay, can anybody tell me the renovascular hypertension?
Renal artery stenosis.
Renal artery stenosis. Okay.
Also fibromuscular dysplasia.
Yes. So renal artery stenosis and also fibromuscular dysplasia. So it will divide into the renal artery stenosis. So this renal artery stenosis may be due to fibromuscular dysplasia. Fibromuscular dysplasia, and may be due to the atherosclerotic lesion, right? Atherosclerotic lesion. Fibromuscular dysplasia. Okay. So can anybody tell me the location of the fibromuscular dysplasia?
Yes.
Distal,
distal
2/3, yes.
Distal 2/3 of renal artery.
Yes.
Distal 2/3 of the renal artery. And it is most common in female.
Females.
So there are many questions on this concept that will be difficult for you. So it is more common in female, right?
Yes.
What age group? Young or middle age? Young or middle age? What about atherosclerotic lesion?
Proximal 1/3 of renal artery.
Proximal 1/3, common in older males and smokers. So older males and smokers. Okay. So primary hyperaldosteronism is also known as Cone syndrome. So in Cone syndrome, increased aldosterone. Increased aldosterone lead to increased sodium, decreased potassium,
Decrease hydrogen.
decreased hydrogen, right? So it will lead
Yes.
to hypokalemia,
Alkalosis.
and metabolic
Alkalosis.
alkalosis, right?
Yes.
Obstructive sleep apnea. So obstructive sleep apnea lead to ischemia or hypoxia. Ischemia and hypoxia lead to increased sympathetic activity. Again, it will decrease renal perfusion. Decreased renal perfusion will lead to increased renin. I already discussed this mechanism, how renin is secreted. So increased sympathetic activity is also activate ultimately renin angiotensin aldosterone system through directly acting on beta 1 receptor of JJ cells, right?
Yes.
Okay, pheochromocytoma. The pheochromocytoma is a tumor of which gland? Adrenal.
Adrenal. Yeah.
Which area?
That would be from
For the
medulla.
Machian cells.
Medulla,
Yes.
right? So,
Yes.
and it will secrete epi
Nephrine.
and norepinephrine, right?
Yes.
So there is cell called chromaffin cell in medulla. So this epinephrine and norepinephrine will lead to the increased blood pressure. Can anybody tell me the treatment of pheochromocytoma?
Yeah. First, we give phenoxybenzamine followed by beta blocker.
First we give
Phenoxybenzamine, which is
alpha
an alpha
blocker
1. Yes. Followed by beta blocker.
followed by
Beta blocker.
beta blockers. So if you give the beta blocker first, there is unopposed activity of alpha receptor because there is an increased epi and norepinephrine is already present because of the tumor,
Yes.
right? First you have
Yes.
to block alpha blocker and then give
Mhm.
the beta blocker.
Yes. A before B.
Okay. Okay, so the next is, did we discuss the pheochromocytoma or not?
Yeah, we discussed pheochromocytoma. You remember we talked about phenoxybenzamine, beta
Okay,
blocker.
okay. Cushing syndrome. So Cushing syndrome is which hormone is increased in Cushing syndrome?
Cortisol.
Cortisol. So how cortisol lead to the increased blood pressure? High cortisol will work as high cortisol work on mineralocorticoid receptors, right?
Yes.
Another mechanism how cortisol increase blood pressure. Increase alpha 1 receptor on arterioles, right? So in this way, Cushing syndrome leads to hypertension. So they love to ask the mechanism, right?
Okay.
Next is thyroid. So the hyperthyroidism lead to increased systolic blood pressure, right?
Yes.
Through beta 1 receptor. Increase beta 1 receptor on heart. And cortisol increase alpha 1 receptor on arteriole, right?
Yes.
Cortisol increase alpha 1 receptor on arteriole and hypothyroidism. Hypothyroidism increase diastolic blood pressure. So the primary hyperthyroidism. So primary hyperthyroidism lead to increased blood pressure. There are a lot of mechanisms of the primary hyperthyroidism. I'm not going to detail in that mechanism that lead to the increased blood pressure, right? So increased calcium lead to the increased sodium reabsorption. It directly increase the arterial tone. So multiple ways it will lead to hypertension. And the last one is coarctation of aorta. Coarctation of aorta. So what is a coarctation of aorta? Can anybody tell me? What is a coarctation of aorta?
Narrowing of descending aorta.
So narrowing of the aorta mean it will lead to the increase.
Afterload.
It will lead to the increase afterload, and if the afterload is increased, increase afterload lead to increase left ventricular pressure. So in this way, it will lead to increase blood pressure, right?
Yes.
These are some mnemonics for the secondary hypertension. Causes of the secondary hypertension, CHAP. So the CHAP, C for Cushing syndrome, H for hyperaldosterone, A for aortic coarctation, and P for pheochromocytoma and stenosis of the renal artery. And another mnemonic is a recent renal causes, endocrine causes, coarctation of aorta, estrogen, neurological and thyroid disorders, right? So I am going to discuss some high yield slide that is a congenital adrenal hyperplasia. Although they are rare, but they are lot of question you found in the NBMEM U world from congenital adrenal hyperplasia. Okay, I'm changing the slide. Congenital adrenal hyperplasia. Although it is a difficult concept, but I will try to help you, right? But this is very important, right? So if deficiency start with 1, is my screen is visible or not? Rock?
Not yet. It's not visible yet.
Okay.
Okay,
Still not
now
visible?
it's there.
Okay,
No, now
okay.
it's there.
These are some rare disorders of the congenital adrenal hyperplasia, right? So sometimes they cause hypertension, right? So there is a general rule. There is a general rule. If the deficiency start with 1, if deficiency start with 1, if deficiency start with 1, it will lead to hypertension. If it end at 1,
Yes.
if it end at 1, it will lead to virilization. Virilization. What is a virilization? Virilization in female.
Masculinization in female.
Yes, absolutely right. Masculinization in female. Okay. So keep this general rule in mind. So 17 alpha hydroxylase, it start with 1. So it will lead to hypertension or not? Yes, it will lead to hypertension because it start with 1. So it will lead to hypertension. Okay. So 17 alpha hydroxylase, aldosterone is increased. This aldosterone lead to decrease potassium and increase sodium, and this increased sodium lead to increased blood pressure through retaining water, right? Although this is
Yes.
a dry topic, but this is a very high yield. So that's why I am going to discuss in the background of the hypertension, right? So cortisol is decreased in 17 alpha hydroxylase. Sex hormone is also decreased and androsterone is also decreased. So they give you the key things: gender, karyotype, and they give you the blood pressure and laboratories, potassium level, right? So blood pressure, potassium level are key things to identify which congenital adrenal hyperplasia, right? So 17 alpha hydroxylase lead to the blood pressure through increased aldosterone, right? What about the sex
Right.
hormone? Is decreased. Cortisol is decreased in 17 alpha hydroxylase, right?
Right.
Okay. So 21 alpha hydroxylase, it will lead to hypertension or not?
No.
So it lead to hypotension. Why? Because there is a decreased aldosterone. If aldosterone is decreased, so blood pressure is also decreased. So USMLE love to ask the arrows question. Love to ask the arrows question, right? So if aldosterone is decreased, what will be the level of potassium? Increase. What will be the level of sodium? Increase or decrease?
No, potassium, if sodium is down, then potassium will increase.
Okay, aldosterone is down, potassium will be down, right? Cortisol is decreased, sex hormone is decreased, and this activity of renin is increased. So it is the most common congenital adrenal hyperplasia, right?
Yes.
So it end at 1. So it will lead to the virilization. Virilization in female. They give you the karyotype. They give you this patient is XX, right? But there is increase here on the face, deepening of the voice that are characteristic of the secondary male character, but they develop in the female, right? So virilization is key thing. 21 hydroxylase deficiency. Okay. Okay. So 11 beta hydroxylase. So it starts with 1. Does it lead to hypertension or not?
Yes, there's hypertension with 11 beta hydroxylase.
So it will lead to hypertension, right?
Yes.
What about virilization?
Yes.
It will lead to virilization, right?
Yes.
Okay. The mechanism of the blood pressure increase hypertension is not due to the aldosterone. The mechanism is due to the increased glucocorticoid, increase 11-deoxycorticosterone. This is a high yield. They ask about the mechanism, right? So the mechanism is not because aldosterone is decreased, but mechanism is increased glucocorticoid. So if there is increased glucocorticoid, it will act on aldosterone receptor as well. Higher concentration of glucocorticoid like deoxycorticosterone or cortisol will act on aldosterone receptors, right? And it will act on aldosterone receptors and it will lead to increased sodium. Increased sodium lead to increased water reabsorption and it will lead to the increased blood pressure, right?
Yes. So, is this the same type of relationship with regards to the 11 deoxycorticosterone? Is it the same type of relationship that you will find with SAME, syndrome of apparent mineral corticoid excess?
Okay, Rock tried to be a simple because this is a very complicated topic. That's why I'm not going into the detail because I give you some general rule, focus on that general rule. It will be really helpful for the NBME and U world. If you follow the one, start with one. So they love to ask hypertension, virilization, what is the mechanism of the hypertension? So these kind of the things, right?
Yes. Yes, I understand that. But the reason I'm asking the question is because you were saying that the hypertension is not because of aldosterone, but
Yes,
it's because of the 11-deoxycorticosterone, right?
yes, yes.
So that's why I
So
was asking that question.
I am asking that is why this is a high yield stuff, right?
Okay. Okay.
Although they are rare disorders, but congenital. So all of these congenital adrenal hyperplasia are autosomal recessive disorders. Autosomal recessive disorders. And they are characterized by congenital adrenal hyperplasia by hyperpigmentation. Hyperpigmentation due to increased MSH. Okay. I'm changing the slide now. I'm moving toward the some pharmacological management of the hypertension. So the mechanism of these drugs are again important. I'm changing the slide. Is my screen is visible or not?
Not yet.
I hope it will be visible. Is this visible?
Not yet. Okay, I think it's coming now. Yes.
Okay. So these are some drugs that are used for the hypertension. Let's start from the pregnancy. So the pregnancy, the mnemonic for the pregnancy antihypertensive drug, new mom, love hug, right? So N for nifedipine, M for methyl dopa, L for labetalol, and H for
Hydralazine.
hydralazine. Okay, so nifedipine is which class?
Nifedipine is calcium channel.
calcium channels blocker.
Dihydropyridine, you are right. And methyl dopa?
Central synthesolytic.
Yes, absolutely right. Labetalol?
Vasodilator, arteriolar vasodilator.
No.
Arteriolar and venous.
Labetalol is which class?
Is non-selective, alpha and beta.
Yes, it's a beta blocker.
Yes.
But it's non-selective.
Yes, you are absolutely right. So what about the hydralazine? What is the mechanism?
Arteriolar vasodilator.
Arterial, yeah.
Arterial. So it is a arterial vasodilator mainly. It's more effect on arteries, right? So if it is more effect in arteries, what will it will do on afterload? Increase afterload or decrease afterload?
Decrease afterload.
Decrease.
What is the mechanism of this drug?
Arteriolar vasodilator.
How? Arterial vasodilator. It acts on the vein as well, but its main action on arteries. So it will lead to increased cyclic GMP. USMLE love to ask this mechanism.
Cyclic GMP. Yes.
Increased cyclic GMP lead to smooth muscle relaxation.
Relaxation, yeah.
Okay. So can anybody tell me the uses of this drug?
Hypertensive,
Yeah, we can use
emergency.
Heart failure.
Heart failure, right. Okay. So any other used with any combination with any other drug?
Yeah, it can be given with beta blocker to prevent reflex tachycardia.
Absolutely right. Right?
Yeah.
And the one of the most high yield side effect of the hydralazine. That lot of questions from that side effect of the hydralazine.
Yes.
Use the lupus.
Drug-induced lupus.
Drug-induced lupus is a very hard drug-induced lupus. Which antibody is present?
Antihistone antibodies.
Antihistone, right?
Yes.
Antihistone antibody. Okay. So we will discuss some drugs that used in pregnancy. What of the migraine?
Methyl dopa.
What?
So the beta blockers,
The drug used in pregnancy with migraine, or what you mean? I didn't hear the question right.
I say that drug used in pregnancy for hypertension.
Okay.
They are new mom love hugs, right? Now I'm
Okay.
going to the migraine. So
Oh.
okay, so migraine beta blocker is used and calcium channel blocker is used, right?
Yes. Yes.
How beta blockers reduce blood pressure, decrease blood pressure? How beta blocker decrease blood pressure?
Blocking beta 1, so decreasing the heart rate and cardiac contractility.
Yes, decrease cardiac output and decrease renin release,
Yes.
right?
Yes.
Calcium channel blocker,
To slow down contractility of
The
the heart.
calcium influx
mainly
into the blood vessel.
mainly non-dihydropyridine calcium channel blocker, right?
Yes. Okay.
So can anybody tell me the non-dihydropyridine calcium channel blocker?
Yes.
Voramidil
You have.
and
Yeah. In the
deltazine.
Philippines.
Sorry,
Yeah. Like in the
Voramidil
Philippines.
and deltazine. Yes.
what is the mechanism of calcium channel blocker?
Well, they will cause I know they cause vasodilation. The dihydropyramine, like the Philippines.
Okay, they act on which
Uh,
channel? Block L-type calcium channel.
L-type.
Yes,
Yes.
it's a
L-type calcium channel, right? On
Yes.
smooth muscle and hard. And in this way, it will lead to the decreased contractility,
Calcium
right?
influx.
Yes.
Yes. Okay. So, can anybody tell me the use of nimodipine?
The cerebral to prevent vasoconstriction in cerebral blood vessel after cerebral hemorrhage,
Yes, it's
to
used in
prevent
subarachnoid
subarachnoid hemorrhage. Yes,
to
yes,
prevent
subarachnoid hemorrhage.
subarachnoid nimodipine is used in subarachnoid hemorrhage. It prevent cerebral vasospasm. So that's why it is used in subarachnoid hemorrhage, right? So,
Okay.
can anybody tell me the side effects? Sometimes they give you the side effect of the drug and they want to ask about the mechanism of that drug. The side effect of the calcium channel blockers are gingival hyperplasia,
Hyperplasia.
gingival hyperplasia, peripheral edema,
Constipation, flushing.
and constipation and flushing, right?
Yes.
Okay. So the drug of choice for osteoporosis is thiazide diuretic. So it's mainly used in thiazide. Can anybody tell me the mechanism of the thiazide diuretic?
Yes. The thiazide diuretic, they act on the distal convoluted tubule and they block sodium chloride
Act
channel.
on DCT. Act on DCT. So in this way, it inhibits
Yes, they will
sodium.
inhibit the sodium chloride channel.
Okay, it inhibits the sodium chloride. It inhibits the sodium reabsorption, right?
Yes.
In this way, it will lead to. So what about the calcium? Calcium.
No, it preserves calcium.
It increase or decrease calcium excretion?
Hypercalcemia
calcemia.
and the hypocalciuria.
Okay. So it will decrease calcium excretion, right?
Yes.
Decrease calcium excretion. So it will prevent the calcium stones.
It's,
Calcium stones, right?
did you say it will prevent calcium stones or it will cause calcium stones?
It prevent calcium stone formation
Prevent calcium stones, yes.
because it will decrease the calcium excretion.
Okay, yes.
But loop diuretic
Yes.
increase calcium excretion. So increased calcium excretion will lead to
Hypocalcemia.
hypocalcemia, and it will lead to increased calcium stone
Yes.
formation,
Yes.
right?
Yes.
Increased calcium stone formation. Okay, so the thiazide diuretic used in hypertension, heart failure, right?
Yes.
It also used in hypercalciuria, particularly idiopathic hypercalciuria, right? So the
Yes.
thiazide diuretic used in hypertension, heart failure, hypercalciuria, osteoporosis, Okay, so what are the side effects of the thiazide diuretic?
Gouty arthritis, hyperglycemia, hyperuricemia.
Yeah, gluc.
Okay, so the gluc is mnemonic. The gluc is mnemonic for the side effect of thiazide diuretic.
drugs.
Okay. So in gout, we used ACE, ARB, right? Or calcium channel blockers, because diuretics lead to hyperuricemia. So avoid diuretics in gout, right? They will lead to hyperuricemia. In atrial fibrillation and flutter, beta blockers and non-dihydropyridine calcium channel blocker. Can anybody tell me the name of non-dihydropyridine calcium channel blocker?
Promobile with deltazine.
Yes, verapamil and delitazine. Right. Okay. Okay, we have shortage of time. We have to conclude this session in 5 minutes, right? So be quick. Okay. So drugs used in hypertension in asthma are calcium channel blockers, thiazide diuretic. Why we avoid angiotensin, ACE in
Yes, because it's going to cause an increase in bradycardia, and the person already has asthma, so it's going to worsen the situation.
I'm saying why we avoid ACE inhibitor in asthma. ACE is avoided in asthma because ACE leads to
this
cough.
dry cough.
Right?
Yeah.
Okay. So why we avoid non-selective beta blockers in asthma? So this is some high.
Because they block beta 2.
Bronchoconstriction.
Okay. So
Yes.
beta 2 receptor lead to vasodilation. Oh, sorry, bronchodilation, right? So if you
Yes.
block the beta 2 receptor through non-cardioselective drug, so it will lead to non-selective beta blocker, it will lead to the bronchoconstriction and it worsens the asthma, right? Drug used in the diabetes mellitus. These are ACE, calcium channel blockers, and thiazide diuretics, right?
Yes.
Okay. So the most important is ACE inhibitors are ARBs. ACE inhibitors are ARB. We already discussed the mechanism of ACE inhibitor in ARBs. We already discussed the mechanism of the calcium channel blockers, thiazide diuretics, and beta blockers, right?
Right.
Okay. So can anybody tell me the side effects of the ACE inhibitor?
Yes. ACE inhibitor
Side
can
effect of
cause
the ACE inhibitor.
it can cause dry cough,
Because dry cough, angioedema, right?
angioedema. Yeah.
And the contraindicated in C1 esterase inhibitors and pregnancy. Okay. They also avoid in bilateral renal artery stenosis. Okay. I am going some
Because
another high yield uh, increase plasma renin. Can anybody tell me the causes of increased plasma renin? So it will increase in decrease sodium intake. You found lot of questions. Decrease sodium intake, it will lead to increased plasma renin. Thiazides and ACE and ARB. Okay, why it is important? Because they love to ask, they in question they give you the scenario that patient is taking that this drug, the characteristic of that drug, and what are the arrows, what are the effects of these drug on renin, angiotensin 2, aldosterone, right? So increased plasma renin takes place in decreased sodium intake, thiazide ACE and ARB. Okay, so hypertension with heart failure, diuretics, ACE inhibitors, beta blockers, and aldosterone antagonists. And these are some the list of the drug that used in primary or essential hypertension, right?
Yes.